Morning everybody, thanks for coming here on a Friday morning. I'm here to present the work of the Working Party, data that we've had from the state government and a number of different sources which we'll go into in more detail. It's really a great opportunity to see what's happening on a statewide level. We all have some concept of what's happening in our own hospitals, and we all obviously think what we're doing is right, but it's good to see what's happening sort of more broadly. I think it's very important to have that collaborative approach. At our previous meeting, we had our working group meeting. We had Professor Gamblin from Medical College Wisconsin come and visit. He was in state for another reason, and he attended. And he said it's really great to see the collaborative approach that we're all taking. He made the point that if they tried to do this in his state of Wisconsin, there's no way you'd get the surgeons from the different hospitals to sit down in the same room at the same time, let alone agree on anything. So I think it really does speak to the collegial nature of our group. Many of us know each other, most of us know each other. So it is good to see, and we've got some very interesting data to present here. So we'll get on with it. First of all, the working group, thank you for all of the work. Special thanks to Luke and Ella for doing all the actual number crunching and data preparation, and Morella and Amy and Megan from the projects team, and my co-chair, Professor Christofian, and the rest of the working group members who have met regularly over the last few months. The aim of the summit is to identify variations in care across the state. It's a starting point for a discussion. It's not a single one-off event. Morella sort of said to me earlier today, it's not it's not like a wedding. You don't do it once and that's it. It is an ongoing process, and we will be meeting after this to actually implement some of these findings. So it's not just a one-off snapshot. It's the start of an ongoing process. And it gives a statewide perspective. So we're going to discuss what the characteristics of pancreatic cancer population in Victoria is, look at some of the incidence and survival data that we have, and then focus really in on the treatment algorithms for those who are deemed metastatic and non-metastatic in this state, and look at some variations in care patterns. No talk on pancreas cancer would be complete without a discussion, in brief at least, on the volumes of surgery issue, but I think it's actually less of an issue than is perhaps perceived. This is the optimal care pathway continuum. We're focusing really on the diagnosis, staging and treatment planning and treatment phases of that. It doesn't have any patient experience data, which is a major gap really in this. And the other area sort of before the start of this is the early detection and what happens at the GP end, and that's really not what we're focusing on here. And there's also virtually no data on palliative care, which I think is clearly a very important component of pancreas cancer. Unfortunately, we know that most of these patients are not going to survive, and palliative care will be relevant to virtually all of them. So that's a deficiency which we've identified, not just a deficiency in the actual treatment, but even the knowledge of what's going on. And we'll go into that more later. These are the data sources from where the information is derived. It's a number of different, primarily government-based sources, all of which are linked by a specific process, which makes it very powerful because you can track patients who have surgery in one hospital and have chemo in another hospital and radiotherapy in a further hospital. And the primary time frame over which we're looking is the 2011 to 2015 period, which is obviously 2 years old, but then it gives us a chance to have at least 1 year of sort of follow-up from the end of that point in time. The inpatient data has a broader set from 2006 to 17. Radiotherapy is similar, and then the death data is, as I said, to actually link it all together and see how patients go. The features of that particular data set is that it is statewide and is reliably linked, and it gives a population level view of what's happening and in general indicative patterns, but it doesn't identify treatment that's not in hospital, which is a major limitation, particularly for outpatient chemotherapy, for example, oral chemotherapies, and it does lack, as most cancer types do, granular detail on staging. Possibly less relevant for pancreas cancer, but in terms of TNM, but more specifically, and we'll go into that in more detail, the characterisation of whether resectable patients and non-metastatic patients are actually resectable or borderline resectable or locally advanced, and that's really a key finding that's arisen from this analysis, that we don't really have that data, which really undermines our ability to talk to the quality of care if we don't know what stage or disease process patients are facing. And it is based on hospital coding, which is not necessarily clinician driven, it's hospital administrative data. There's some assumptions and use of proxy data. For example, the diagnosis of metastatic disease for the purpose of this data set is diagnosis of metastatic disease within 4 months of treatment. So specifically, therefore, patients may not have visible metastatic disease, but if they flourish that within 4 months of the time, they're said to have metastatic disease at the time, which I think is a reasonable assumption. And the other limiting factor is the Murray River. Patients treated in the Hume region can be treated across the river and therefore are lost. So virtually everywhere you see the Hume data, there'll be an asterisk saying that that's essentially incomplete because we don't know what happens across the border. We have some other registries we've derived some data from. The first one is the Purple Translational Registry, and Belinda, Peter are here today. That's an ongoing multi-centre prospective cohort of pancreas cancer across 27 centres in Australia, New Zealand, Singapore. It's a convenient sample as opposed to a population-based sample, but it does provide really excellent clinician-driven granular data. Obviously, the limitations of that is it's not statewide, and somewhat of a referral bias. I guess they have a higher proportion of early stage cancers in that data set, but it does provide useful information to us, and we'll speak to some of the data that's available from there shortly. And the third, data source, John Zalksberg and Dan Crow both here as well, was the Upper GI Cancer Registry. The pancreas module was the first module to be rolled out in that regard in a pilot phase in 2016. Currently up to 220 patients and aiming to cover 30 hospitals and therefore 75% of Victorian pancreatic cancer cases by mid next year. And that's really links in with the translational registry of the Purple database and the statewide hospital administrative data, because the Upper GI Cancer Registry is really a quality registry, and we've just recently, 2 or 3 weeks ago, had a modified Delphi panel meet in New South Wales to further refine those quality indicators, and it will really be complementary, the data that can be derived from that registry, which will expand beyond the pancreas module, and is currently working on the OG module and subsequently liver and biliary modules. So we all know what the ICs are, we all know where we come from, and this is the state-based layout of how the integrated cancer services are distributed and where the regional cancer centres and comprehensive cancer centres are located. As we all know, they're state-funded programs to integrate cancer services, and they link groups of health services and clinicians, meaning that there's work across organisational boundaries, which is sensible in the sense that a lot of clinicians work across organisational boundaries. It's rare for a clinician to work at only one institution, and it therefore focuses on the needs of the population rather than on an individual hospital, which I think is very useful and has been a major step forward in the provision of cancer services in Victoria. So that's all the preamble. Now we'll talk about some of the actual data that we have, and start with the demographics, incidence and survival. As we know, it's a disease of the elderly, median age of 73, higher proportion of men. The comorbidity score, which this is all risk stratified for, is based on the Charleston Comorbidity Index, which is a fairly extensively validated comorbidity index, which doesn't include every comorbidity known to man and does require coding accuracy. There is an increase in patients across the years, 2011 745 to 850 in 2015, and that's an increase per head of population as well as an actual increase. And overall, that 5-year period, there's almost 4,000 patients with pancreas cancer that we can just speak to. So, it really is a great data set, and we all think of our individual hospitals, and we've done 150 Whipples for this, and it's sort of talk about 4,000 patients with pancreas cancer is really a unique opportunity, and it really gives us an idea of what the reality of pancreas cancer is, in this state. The regional or the integrated cancer services have a differential distribution of patients' SES's socioeconomic status. and you want to be in 5, which is the least disadvantaged, and that is discrepant across the integrated cancer services. Again, it's risk stratified when we assess for the differences in the ICS, because clearly there is a relation between socioeconomic status and outcome, as we'll see later, and it's also a surrogate perhaps for other issues such as smoking and so on. The average rate of metastatic pancreas cancer is 60% across the board, and as I said earlier, that diagnosis of metastatic cancer in this data set is including those who have metastatic disease within 4 months of initial diagnosis. And the predictors of cancer are, again, older patients, male patients, and as we see here, those with lower socioeconomic status do have an increasing risk of pancreas cancer, which may be a surrogate for other measures, but is certainly true and therefore relevant to risk stratify for. This is a pleasing slide. There has been a slight but a real increase in 1 year survival for pancreas cancer over the time. Overall from 23% to 34%, which is actually 27%, sorry, to 34%, which is a nice figure to see. It's a fairly static cancer over 40 years, so even a marginal increase is pleasing. And patients who are older do worse. If it's not in the head of the pancreas, do worse. If they're comorbid, they do worse. And if they have a higher socioeconomic status, they do better, which is what is demonstrated here. This information is in front of you as well, incidentally. There's a slide booklet in front if anybody wants to take notes, in case there's any questions at the end. I'm happy to field those. So that's the overall demographic sort of snapshot. The treatment planning for pancreas cancer, we all know that we all want these patients discussed at MDTs, and we also know that not all of them are. The target is 80%, the average is sort of 68-70%. In the Upper GI Cancer Registry, similar numbers, again a quality registry which will focus on that as an outcome measure, but we're really not talking about every patient. And when we know that 60% of patients have metastatic disease, it's likely that the majority that aren't discussed are metastatic, widely metastatic, and not felt to be necessarily added value to discuss. However, I would argue that those patients should be discussed because there are clinical trials and there is referral to palliative care, and the whole point of multidisciplinary care is that we all see the same thing and talk about every patient. So I think that is an area we can do better, and I think that is, we'll have a discussion in the later session about whether we all think that's important. It's fairly sort of hard to argue that it's not, but it is a structural thing because we all have MDTs, and Sam Ellis can speak to the fact that we had 25 patients in our MDT yesterday, and to add another 15 metastatic pancreas cancers means that the meeting goes until the next day. So it's a structural thing, and we may need to move to having a pancreas specific MDT. Certainly when I did my fellowship in the US, we had a specific pancreas tumour board separate to a liver tumour board, and I think that with the subspecialisation we're seeing, just having an overall upper GI MDT, when we want to talk about every patient, may not be the way forward. We may need to look at measures of improving that by having specific tumour MDTs, and that requires funding because it requires extra meetings and extra attendance and so on. But if we agree that that's an important area to work to, then we clearly have the data to back up that we're not doing what we should be, and could be a useful outcome from this summit. And it's not just our hospital; it's all hospitals. Nemics are doing very well, and I'm not sure because I'm not in that network whether they do have a specific pancreas board, but I think that it's an area of need and an area we can do better. So the actual treatment for pancreas cancer, and this is pancreatic ductal cancer. We do have data. There's 4,000 patients are all pancreas cancer types. Obviously, the majority of pancreas cancer is pancreatic ductal adenocarcinoma, and from here on we're just discussing that because clearly patients with neuroendocrine tumours, cystic tumours, have a vastly different survival curve and treatment algorithm. But this is just pancreatic ductal cancer we're now talking about. The characteristics associated with treatment, not surprisingly, younger patients and fitter patients are those who are actively treated. Overall, no discrepancy between ICS and also pleasingly no discrepancy between those who are of higher or lower socioeconomic status. So I'm just going to focus a little bit on this table because I think this really is, the single table that describes the treatment for patients who are potentially curative, although I say that, with a glum tone because we know that the overall survival is still poor. But those who are non-metastatic and therefore don't become metastatic within 4 months of this diagnosis, this is how those patients are treated in Victoria over this 5-year time period. So 1,000 patients, again, huge data set when you consider, our individual hospital volume. So 1,000 patients with non-metastatic pancreas cancer. What we see, I'll try and use this pointer here. What we see is out of 1,000, 16 have pre-op treatment and then go to surgery, whereas 319 go directly to surgery. So surgery first is what we are doing in this state. And that accounts for about a third of the patients who have non-metastatic pancreas cancer. From there, 260 odd have adjuvant therapy, meaning that 76 don't have any adjuvant therapy. And I think that's a really important single, snapshot of what's happened to these patients. So we've just finished saying that most patients with pancreas cancer die of pancreas cancer. We all know it's a systemic disease, therefore it all needs systemic treatment. And a significant proportion, a quarter of patients who are treated with surgery never get any systemic treatment, and ultimately we know will die of systemic disease. So I think this is a very important finding. And the other important finding is virtually nobody is getting neoadjuvant therapy. What we don't know here, and it's highlighted by this sort of arm here, a third of patients only get systemic treatment and they never get surgery. They may be patients who are locally advanced. We assume that those patients have locally advanced disease and are not appropriate to have surgery, but we just don't know. And I think that's a really glaring discrepancy in our knowledge and understanding of pancreas cancer in Victoria. We don't know who has borderline resectable pancreas cancer. We don't know who has locally advanced pancreas cancer. And therefore, it really becomes very difficult to speak to the quality of their care if we don't know what we should be treating them with. If they're having chemotherapy alone because they have locally advanced, completely appropriate. If they're having chemotherapy and never coming to surgery but they're resectable, completely inappropriate. So we really need to know who has locally advanced disease, and we really need to know who has borderline resectable disease. And that comes back to us as clinicians to clearly document that. In our radiology reports, it should be clearly documented. In our MBTs, it should be discussed and agreed that it's borderline or it's resectable or what. And then the government and the state needs to be recording that, because then in this sort of forum we can say, well, these patients have locally advanced disease and are appropriately treated, or not. And again, that will be a way of measuring variation across the ICS. So I really think that's critical, and I really think that's a very important, problem that's sort of arisen from basically this table. Is they're all non-metastatic, sure, but we don't know anything more about them, and we therefore don't know, where the borderlines are being treated and how the locally advanced are being treated. We assume they're mostly locally advanced. Interestingly, also another third of patients don't get any treatment at all. Most of those are elderly with more than one index or die soon after diagnosis, so appropriately not treated is the assumption. But to summarise then, a third to surgery first, a third definitive chemotherapy, a third no treatment. Because there were this group of patients that didn't seem to have any reason to not be treated, we looked into that in a bit more detail of a small sample of that 76. In fact, the majority had a good reason not to have any treatment. The comorbidity profile I mentioned at the start is assessed in this context with the Charleston Comorbidity Index. Doesn't pick up every comorbidity. Patients who have severe limiting schizophrenia and reasons to not undergo major resectional surgery, uncontrolled hepatitis C and so on, and cirrhosis may not be captured by the Charleston Comorbidity Index. So that and an additional few patients who actually were found to have metastatic disease, who didn't have records and so forth, basically accounts for all those. So I think we're okay that we are treating patients who should be treated and not treating patients who shouldn't be. But then, as I say, I come back to really the systemic treatment, and sure, 77% did have adjuvant therapy, but it means almost 1 in 4 treated with curative intent didn't ever get any systemic treatment, which I think is really a poor outcome for us. We don't know why that is. Did that patient refuse? Were they too sick? Were they still in hospital? There are a number of reasons that may be the case, but it still is still the data. You know, a quarter of patients didn't get any systemic treatment, and virtually no patients had neoadjuvant therapy. We discussed this in our working group, and people said, "Oh, well, that was a few years ago." But in fact, the GAP trial of adjuvant therapy, neoadjuvant therapy for resectable pancreas cancer started right in the middle of this time period. So it was on the radar. It was something which we were considering and looking at, but no one's getting it. Most guidelines recommend patients who have more borderline resectable disease should be treated with neoadjuvant therapy prior to resection. I've just finished saying we don't know how many are borderline. What I can tell you is they're not getting chemotherapy in a neoadjuvant setting because no one is. Either borderline resectable pancreas cancer is getting chemotherapy and then not surgery, which is inappropriate, or they're getting surgery up front, which is also probably inappropriate. So I think it's sort of reading between the lines a little, but I think that we're not treating borderline resectable pancreas cancer appropriately, even based on this data and even without knowing how many patients have borderline resectable, because they're not getting neoadjuvant. So they're either not getting the chemo or they're not getting the surgery, but something's going on with that patient group. We've said a third go straight to treatment, probably locally advanced, and they're actually doing okay. You know, 62% of those patients with locally advanced treated with systemic are still alive a year later. And a third are old and sick and appropriately not necessarily treated. So this is a slide from the Purple Registry, which looks a bit more closely at exactly what I've just been saying we don't have on a state level. That is the breakdown of borderline, locally advanced and early stage. As you can see, they have a smaller proportion of patients who have metastatic disease or diagnosis in that data set. But, you know, virtually the same number of patients will have borderline to locally advanced as resectable. So of the non-metastatic, at least half of them are going to be either borderline or locally advanced if we extrapolate from the Purple Registry. So I think it's a real a problem, and it's not just a few patients that are borderline and not necessarily getting treated. I think it's a real issue that we're seeing here. Moving on to treatment timing, the optimal care pathway states has been agreed upon that 4 weeks from diagnosis to treatment is appropriate. Are we doing that? Well, they're the neoadjuvant therapy patients, and they're all being treated within a month or so. There's only 13 patients, and 9 of them were treated within a month. Doesn't really mean much because it's such small numbers. This is also a little bit misleading because the diagnosis was established at the time of surgery, you know, by definition, because that's when the histology is available. So, you know, time from diagnosis to treatment of 0 days doesn't mean we're operating on people in the consulting room. You know, it's just a definitional thing. Time to definitive chemoradiotherapy is a little bit longer, and less than half the patients are being treated within a month. If you do get those patients who do get neoadjuvant, they wait about 4 months until they have their surgery, which is about right. You know, if you're giving somebody neoadjuvant intent chemotherapy, it's about 4 months in between the start of chemo and their treatment. And then the time after surgery to chemo or chemoradiation is also an interesting number, and that's about 2 months, which is also probably longer than it should be. You know, ideally we would want to start treatment within 6 weeks, and that's just a bit beyond that. But again, that speaks to the fact that patients are sick and in hospital and so on. So if we look across the board, this is also quite interesting, a slide with a lot of data on it. The blue is the surgery, red is the chemotherapy, and the mustard colour is radiotherapy. And this is comparison across the ICS, risk adjusted for age and comorbidity. So what this is showing is that if you're anemic, you're more likely to get surgery than anywhere else. If you're on the SMICS or the Besrix, you're more likely to get radiotherapy than anywhere else. So this is showing variation in care across the ICS, which is not necessarily what we want. We want to all be agreeing on and doing the same thing. But even risk stratified, there is differences in the treatment. Most of the time it all crosses the axis. This is the star which I was talking about. in every time you see HRICS. Most of the time it crosses the odds ratio of 1, meaning no difference, but every now and then there is a difference, and those three are the most telling. The more likely to get surgery in NEMICS, more likely to get radiotherapy in SMICS or BERSRICS, and that is a potentially unwanted variation. Perhaps this is where we all should be, operating at the same frequency and NEMICS. Perhaps this is where we should be, giving radiotherapy to everybody. But what it flags at least is there is a difference in treatment, variation treatment. Outcomes post-surgery. This is a pleasing slide. Our 30-day mortality is world-class, 2% across the state, world-class 30-day mortality, and a 90-day mortality of 2.7%, also world-class. So I think we're really doing very well in our outcomes. If you compare anybody's numbers basically in Victoria to anybody in the US, everything's low volume, basically. But we're world class in our mortality figures. Our median length of stay is 13 days. Doesn't change much across any of the groups of doing it. There's always outliers. We've all got patients who stay for 6 months. That's the nature of pancreas surgery. But the median is 13 days, which is pretty good. Most patients across the ICS go to ICU, and most of the time it's for about 2 days they're in ICU. There's not a lot of variation there, which is good to see. Again, this shows some slight variation across the ICS. They're more likely to receive chemo if they're in SMICS or GRICS, and again it is adjusted. And again, in that granular data from the purple registry, what are patients getting? They're basically still getting GEM as a single agent. Even with the interest in FOLFIRINOX in this cohort up to this year, only a handful of patients in that registry are getting either Gemabraxane or FOLFIRINOX, which I think is quite interesting. Again, we all have a concept that we're all moving towards Gemabraxane or FOLFIRINOX where we can, but it's really not happening. The majority of patients are still getting gemcitabine single agent. Where are patients treated? The majority of patients receive surgery in the metropolitan ICS. So this slide shows where they live and then where they get surgery. So if you live in NIMICS, you get surgery in NIMICS 80% of the time. And if you live in LIMICS, then you don't get surgery in LIMICS. You go central. So this is basically showing that patients come to the city for their surgery, which is what we all know. And similarly, if you are having chemotherapy, that's mostly local. Most of the time, you do get chemotherapy local, which is also appropriate and sensible and what patients want. I'm not a patient, I can't speak to that, but I think patients want to be treated closer to home where they can, but are also accepting of the volume outcome relationship that is inherent in major surgery and are prepared to drive to the city to have a major case. Nobody wants to drive to the city to have their gallbladder out, but if you're going to have a 5-hour Whipple operation and be in hospital for 2 weeks, in ICU for 2 days, then patients are prepared to come to the city in the majority of cases, as is shown by the data. But if you're going to have 3 months of chemotherapy or 6, you want to be at home for that, and that's what's happening and is appropriate. As I said, we've got to talk about volume of surgery because everybody will ask. So here's the data. For the 14-15 year, there's a significant tail and a number of low volume hospitals in private and public. But excluding that tail, most hospitals that are doing this sort of surgery are doing 10 or more. Significant outlier in the private world where there's 6 pancreas surgeons doing a lot of work. But on the whole, most centres are doing sort of 10 or more with a few with a tail. Flagged an issue, so we looked into it a bit further. So of those 10 health services reporting 14 to 15 are doing 3 or fewer. The next year, even fewer hospitals were doing that many, and then last year, virtually none. So I think it's sorting itself out with time, that places and centres aren't doing 2 or 3 cases a year. It's a natural sort of process that patients are being centralised. So I don't think it's an issue, and I don't think it's something we need to get unnecessarily, worked up about. We did look at the data, and there is a lower hazard ratio, but not statistically significantly so in terms of volume and survival. But the problem is the low number of patients we're talking about. You know, if it's a hospital that does one pancreatectomy a year, you know, they're going to be doing 5 pancreatectomies over 5 years. It's very difficult to statistically show that they're going to do poor because of the statistics of low numbers. We're touching on metastatic disease. This is the same sort of slide as we saw for the non-metastatic, but the difference being, not surprisingly, virtually everybody either has chemo alone or nothing. There were a few patients that went to surgery, but when we looked at those in more detail, they were found to have metastases at surgery, so that's fine, that happens. You know, you don't know they have metastases and take them to surgery. You take them to surgery and find them to have metastases, so you've operated on someone with metastases. That's not really inappropriate necessarily. This number is not concerning because it's only 29 patients out of 2,000, but these patients had surgery and then within 4 months had a metastatic diagnosis. That is a bit disastrous. You don't want to be doing a Whipple and then within 4 months having a patient flourish mets. Again, because we don't know if these patients are borderline, we can't really comment as to should they have had chemotherapy first. You kind of suspect maybe they should have, but there's no way of speaking to that. Clearly neoadjuvant therapy will eliminate those patients, because if you're giving someone neoadjuvant therapy, they'll flourish metastases if they're going to before you take them to surgery. But you know, as a volume of patients, it's 1%. 29 out of 2,000, so not a huge number. But basically, half and half either get no treatment, again because they're mostly old and sick, or get local therapy only. Only 4% of patients actually got surgery, and as we said, most of those are found to have disease at time. So of the 2,000 that didn't get any treatment, majority old or comorbid. A few that didn't, again, either just had endoscopic intervention alone or palliative care as an inpatient. Brings us on to palliative care. There's no statewide data on palliative care services. We have good registries for radiotherapy, chemotherapy, but really no statewide data on palliative care, and that's a deficiency in our data set. Given the poor prognosis, it's something we would like to have more information on, and we know that the role of palliative care is very important. The optimal care pathway does specify it should be timely and may require referral additional diagnosis. I think there's a reluctance to do that because of perceived we're not going to treat you going with palliative care, but I don't think that's appropriate or accurate. Clearly if there's early or on recurrence or progression, there should be referral to palliative care, and they are a core member of the team and they should be present in our MBTs. We do have some data from the Palliative Care Outcomes Collaboration, and over the country, only 7% of contact of palliative care physicians is for pancreas cancer. And from the UpGI Cancer Registry, there were the majority of patients who were deceased did have referral to palliative care at some point, mostly as an inpatient, and the average we see here is the majority of patients with pancreas cancer are dying in hospital, higher than other GI cancers because it's a nasty cancer. So I think the take-home message is that specialist palliative care should be involved early during active treatment. Not a lot of necessarily good value in waiting until the patient's a peri-mortem before referring to palliative care. They should be involved earlier in the process and should be delivered progressively and concurrently. So that's the data. The summary, I think the positives are that our 1 year survival has increased marginally. I'll take any benefit. Our post-op mortality is world class. As I said, 2% 30-day and 2.7% 9-day mortality is as good as anywhere in the world. And the volume of surgery issue, there is centralisation happening without mandation, which I think is good. The volumes are generally 10 or above, which I think is appropriate, and very low volume centres are sort of selecting themselves out. What do we need to know? Well, clearly I've identified that palliative care we don't have any good data on. What are the barriers to it? What are patients' and clinicians' perspective? That's an area that we need more information on. And then, as I said, staging data, not so much T&M staging, but really the identification of locally advanced and borderline resectable is the most glaring discrepancy in this data set. And it's the biggest thing which undermines our ability to talk to the quality of pancreas cancer treatment in the state. So I think that needs to be a priority, and is a process of we as clinicians and government needs to agree on, and therefore collect data on and provide data on, so that we can make more sensible comment in the future. We don't have any data to evaluate the quality of surgery, resection margin status and so on, but the quality registry that John and Dan are running, I think, will go a long way to address that and various other quality measures, sort of granular clinical quality measures. In terms of variations in data, variations in treatment, as we've said, virtually nobody's getting neoadjuvant therapy, and I think that's a problem. And a quarter of patients who have curative surgery, intended curative surgery, don't receive any systemic treatment, which is clearly also suboptimal. The patients who are only getting chemotherapy or chemoradiotherapy and are therefore probably locally advanced are actually doing quite well. Their 1 year survival is comparable to those who have surgery. And there are variations in specific treatments, and the most telling is the increased the increased likelihood of having surgery in the NEMICS group. And the reason for that is unclear, and then some regional variations, as I said, also in radiotherapy. Treatment planning in MDM is ubiquitous across all tumour streams, but certainly equally true in pancreas, if not more so than other tumour types, because of the large number of metastatic cases which probably never discussed, and which will require structural change in the hospital and the funding models. Timeliness of care, the median time frame of 5 weeks is close to the 4-week mark, but is an area we can do better. The volume of surgery we've spoken to, and most patients are still dying in hospital, and so palliative care is a critical area of need. So that's the data and the presentation. Again, thank the Working Party and for the opportunity to present it to you, and for Catherine and we feel from the state government, and the funding of the cancer summits is from the ICS and the DHHS. So if there's any questions, I'll be happy to field them as best as I can.